As podiatric surgeons, one of the least favorite procedures that we perform are amputations. Nobody wants an amputation. Everyone wants to keep as much of their body intact as possible. However, leaving what normally is considered perfectly healthy tissue attached to the body may, in some ways, be considered unfavorable. Sounds crazy, right? So that's what we're going to be talking about today in Dr. K's journal article review. So the title of this article is Deliberations about the Functional Benefits and Complications of Partial Foot Amputation. Do we pay heed to the purported benefits at the expense of minimizing complications? This is published in the Journal Archives of Physical Medicine and Rehab in 2013. The authors are Michael Dillon, PhD, and Stefania Fatone, PhD. Both are experts in prosthetics and orthotics in Australia and in Chicago, respectively. I just want to make some definitions just to start off, just so we are all on the same page as we're talking. When we talk about partial foot amputations, there's different levels of it. I'm going to put a picture up here. You'll see that once we cut the toes off at the level of the metatarsal phalangeal joint, that is a disarticulation through the metatarsals. You'll call it a transmetatarsal amputation, or a TMA, I might say. If you disarticulate at the tarsometatarsal joint, some people call that a Lisfranc amputation. Proximal to that is called a Chopart amputation, and there's varying levels of all between this. And unfortunately, if somebody gets an amputation like a TMA, if too much foot is left, occasionally you'll have to go back in the operating room. It could be that same admission, it could be months later, and you're gonna have to take it back even further. And it happens all the time. Let's talk about the article again. So, abstract. When we're deciding the level of the amputation, your surgeon's going to choose whether you're going to either, one, leave as much of your foot as possible, or two, choose an amputation level where they will provide the most function. Also, when we talked about the levels of amputation in the foot, there's also something called a below knee amputation, or transtibial amputation. So this is probably one of the most functional ones because they can fit a prosthetic very, very well. There's also above knee or transfemoral amputation, and it's exactly what it sounds like. And then there's a hip disarticulation, which is pretty significant. That one has very, very poor mechanics for walking, obviously. Okay, so when deciding the level of amputation, the doctor's going to choose whether he's going to leave as much foot as possible or he's going to leave as much of a functional limb as possible. And those are two very different things sometimes. When deciding the level of the amputation, your surgeon's going to want to choose either one, to leave as much foot as possible, or two, to leave as much of a functional limb as possible. And those are two very different things. When you leave as much foot as possible, you are running the risk of a patient having to go back to the hospital, and they're going to have to get another admission. They're going to be getting IV antibiotics. They're going to have potential wound issues. Their healing is not going to be very well done. They could be in your office every week for years to try to heal this wound that you're making because you want to preserve this much foot. So why would you ever want to decide, other than the lofty idea of keeping as much foot onto you as possible? Some of the excuses doctors have used to leave as much foot as possible, this particular study challenges those. And we're going to talk about these three beliefs and what the evidence is for and against them. So belief number one, preserving the ankle joint and residual foot length allows push-off and a more normal gait. The article goes on to say that the only study that really proves this or even discusses this is a single case study where the strength of the ankle joint was measured at amputations at different levels. And pretty much once the metatarsal heads have been compromised, meaning anything proximal to a metatarsal phalangeal joint disarticulation, a type of partial foot amputation, the ankle motion is going to be the same. For an ankle power and the gait changes are going to be the same regardless of the future level of that amputation. So once you go past that proximal phalanx, you are no longer going to have a normal gait. You're no longer going to have power generation at the ankle. So it's amputation at any of the partial foot levels results in the same loss and ankle power generation that occurs with a transtibial or below knee amputation. So once you go past those metatarsal phalangeal joints, functionally, gait-wise, it's the same as having a BKA. Also comparable to partial foot amputations and below knee amputations are the compensatory gait adaptations at the hip and the self-selected walking speed. Those things are the same, nearly the same, and a negligible difference. There's a negligible difference between these levels. All right, so belief number 2. The gait of a person with a partial foot amputation is less energy expensive than somebody with a below knee amputation. Now the authors, when they discuss this, they're using studies that use oxygen consumption as a determinant for how much energy is used when somebody's walking. And some of these studies, they're not exactly the strongest kind of studies, because a lot of times patients are going to choose the self-selected walking speed that's going to make it so that they're not, sweating when they're walking. So the author of this study points out that energy expenditure is measured with oxygen uptake, and if the study allows self-selected walking speed, the energy expenditure between the varying levels of partial foot amputation and below knee amputation are unlikely to be significant. However, if there is a above knee amputation or hip disarticulation, there is a significant difference. So again, you don't have the big difference in energy expenditure when you comparing a below knee amputation to any of those other foot level amputations. Just doesn't exist. Invalid excuse. Belief number 3. People with a proximal foot amputation have a better quality of life than people who have a transtibial or below knee amputation. So there are some investigations in the quality of life that for patients with these different levels of amputation, and believe it or not, they're relatively the same. Patients have, what they measure in these studies are things like bodily, pain, general health, physical functioning, social functioning, and mental health. These are relatively close. The margins of error are equal to each other. This is comparing below knee amputation to partial foot amputations, not proximal to the knee. So there goes another invalid excuse. And not mentioned in this little section here, but in the discussion, which we're going to talk about, is what about the quality of life for a patient who has to return to the hospital 3 times in a year and get 3 different amputations on the same foot, one more proximal than the next? What happens when that patient's kidneys go out because they had bad kidneys to begin with because of poorly managed diabetes, and then now with all the vancomycin that they've been getting, they've got their kidneys get shot, and then they end up on dialysis? What's the quality of life of a patient then? The time away from family. He spent Christmas in the hospital because we decided that we were going to try to keep as much foot as possible. I think these are important considerations for you as the patient. If you're watching this video and you're wondering why my doctor wants to give me a below knee amputation, these are the kind of things that the doctor is considering. And you as a doctor, if you're not willing to let the patient's leg go, you're not doing the patient much justice. You have to be considerate of all these things. Otherwise, you're going to hurt your patient. You're going to make their quality of life worse for no reason. Discussing with a patient that hey, listen, babe, homeboy, friend, we're going to keep as much of your foot as possible. That's tempting to say. You want to say it to them. They're going to be like, yeah, that's exactly what I want. I know. It's important for you as the patient, it's important for you as the doctor to know when it's time to tap out, because it's not as bad as you think. It's not as bad as you think when you have the below knee amputation. In fact, I've seen patients personally, there's anecdotal evidence obviously, who have painful feet because of peripheral vascular disease, and they have amputation after amputation after amputation, and not until they have the below knee amputation do they end up they regain the color in their face, they regain weight. They regain happiness in their lives. And hey, Mr. S, how you doing? I haven't seen you in a while. What are you doing here in the hospital? Oh, my wife is sick. Like, you look like you gained like 30 pounds. How you been? He goes, I got the amputation, and and all the pain went away. So that sometimes you need to know when to tap out. That's why I think this paper is actually kind of important, and this will be the first of our journal article reviews. And if you like it, please give me a like, give me a subscribe, and just remember, every day is the best day of your life.